we're going to run through an approach to a failed airway. So some of the things you might look for to identify a failed airway during the strategies you might be implementing would be things such as a poor ability to ventilate, which might be evident with a brick bag, poor seal, no chest rise and fall, no sounds heard on auscultation, as well as things such as declining SpO2 despite oxygenation or attempts at oxygenation, or dropping end tidal or a poor end tidal CO2 waveform might also be indicators that you're heading towards a failed airway. I know you might have contributing factors that indicate that you're already going to have a difficult airway, which might suggest that you jump further ahead in your failed airway algorithm. So these may be things like physiological anomalies such as obesity, distorted facial or neck anatomy, obvious obstructions, it's things like that. So in the setting of your failed airway, so some of the strategies you would ideally aim to go for in terms of your algorithm would be initially to attempt an endotracheal intubation. So this might be with a stylet or a bougie initially. So failing your first attempt, when you're starting to identify you could be heading for a difficult airway, some troubleshooting options might be to change and attempt to re-optimize the patient's position, changing the blade size on your laryngoscope or going to a video laryngoscope, going to a smaller endotracheal tube size, changing your introducer, utilising additional operators to assist with the technique. So failing 2 attempts at an endotracheal intubation, you may then start to progress further into your algorithm to things such as a supraglottic airway. So again, you can attempt this with differing sizes, aiming for deeper attempts at insertion, lubrication, repositioning. Failing this, you would then be ideally aiming to try and oxygenate the patient in a can't intubate scenario. So this may be the use of a bag valve mask, two-handed technique, additional operators to assist with the seal, utilising OPAs and or multiple MPAs. Anything you can to try and optimise oxygenation. Failing this, you may then be in a situation where you can't ventilate and can't oxygenate, can't intubate, and you're now looking at a situation where you're going to have to go down a surgical airway, an emergency airway. So some indicators for this with Ambulance Victoria are unconscious patients where basically every other adjunct, your OPA, MPA, supraglottic airway, bag valve mask and ET tube have all failed. So these might be situations where an RSI is either not authorised, cannot be facilitated because you can't obtain IV or IO access to provide the relevant pharmacology. Situations where an RSI can't be attempted due to significant facial trauma or injuries where you wouldn't be able to proceed down the difficult airway pathways. Situations where you have an obvious obstruction or foreign body that would not be able to be removed with McGill's or other techniques, or partial obstructions where an air ambulance retrieval is going to be required and there's no additional skill sets available to consider other techniques. So the contraindications for Ambulance Victoria, there actually isn't anything that prevents you from attempting this in a can't intubate, can't oxygenate scenario. The only consideration is that the road ambulances with Ambulance Victoria don't carry appropriate ventilators to place a patient on a ventilator once you've obtained a surgical airway. Air ambulance with Victoria is different, and I believe that they can use these techniques with a ventilator. So in addition to this, we would then look at optimising our can't intubate, can't oxygenate scenario by going through the steps to prepare for a cricothyroidotomy. So whilst you're doing your preparation, ideally you would have another operator continuing with attempts at oxygenation, either with a subglottic airway or with a bag valve mask, so that you're still attempting to provide oxygenation while you prepare. So you want to identify your thyroid and cricoid cartilage, and between this is where you would find your cricothyroid membrane. So you would ideally want to mark this with a horizontal line. Ideally you would double check this with another operator and have this confirmed prior to commencing. So we have our equipment placed out here. So in Victoria we use a Quick Track 2 device. So we have our swabs prepared. So in the setting of this being an emergency procedure, the idea is to aim for clean as opposed to an aseptic technique. So ideally you would still attempt a swab. You have a scalpel, we have our device here. We would have already checked that our cuff inflates, and then we would fully deflate this prior to commencing. We have our foam tie here that will help secure it, and we have our BVM with our appropriate adjuncts and a sharps container as well. So ideally we want to aim for PPE, so we would have our gloves, goggles. Some texts also suggest using a mask, either one that just covers your nose and face, or ones that have the big plastic shield, as you may see in obstetric scenarios, just as this may be a potentially bloody procedure, and you're obviously trying to prevent any contamination as well. So with our PPE in, we'd ideally be aiming for a hyperextended position for our patient. So we've swabbed our area. So we want to make sure that everything that we do skill-wise is being done with our dominant hand. So our non-dominant hand, so in this case my left hand, is going to stabilise. We're going to do our incision. So it's a 1 centimetre vertical incision to 2 to 3 millimetre depth, whilst maintaining traction with your other fingers. So now that we've got our incisions, some considerations might be in this setting: if you have a patient that has a particularly edematous neck, or you have a situation where you can't palpate the membrane, then you may need to consider a bigger and or wider incision, and then physically palpating with your finger to find the membrane prior to the incision. So we've done our incision, we've got our Quick Track 2 device. So again, in my dominant hand, so we're going to attempt to insert at 90 degrees, considering this may need to be quite firm pressure, down to the red stopper, which is in place to ideally prevent you from penetrating the posterior tracheal wall. At this point, you would then tilt back to a 60-degree angle, and we're going to aspirate. So in some services, they actually fill this syringe with water so that you would see the air bubbles as opposed to having to listen for them. So providing that you have, you are able to aspirate air, then you are believed to be in the trachea. So we would remove the red stopper, and we now attempt to feed off our cannula here until we get an audible click. This may need to be a two-handed procedure or even a second person. So we get our audible click, so we're then going to feed the cannula off there, and our syringe is going to pop off the back. So your sharp goes straight into a sharp container. So you would then use your other syringe here. We're going to inflate the cuff, and then we're going to confirm our position with ventilation. So looking for chest rise and fall. So we want to initially give 1 to 2 rescue breaths, so aiming for 6 to 7 mils per kilo. So once we have this confirmed, we would then get a second person to continue our ventilation. So 67 mils per kilo at 12 to 16 breaths per minute, or whatever is clinically appropriate, and confirming with an end tidal reading as well. Bearing in mind we may need 6 or 7 breaths to be able to confirm an appropriate waveform. So we would then use our foam necktie here to confirm this in place. So some post-procedure considerations may be ongoing sedation and or paralysis for this patient, as we obviously don't want them to be pulling this out. And obviously just maintaining the position of this and reconfirming constantly with end tidal and other adjuncts to make sure that the position doesn't change during any transport. And this patient will obviously need to go to a high acuity facility as well.